Hi guys, welcome to next level ophthalmology. Today will be the last class on orbit and today we'll deal with orbital trauma and orbital surgeries. So under orbital trauma we'll be covering orbital emphysema, hemorrhage, orbital compartment syndrome, fractures and foreign bodies. In orbital surgeries we'll be dealing with orbitotomy and orbital extension. So what is orbital emphysema? Emphysema, the word says that there is air present within the orbit. So it is a benign condition in which the air enters the orbital cavity. Normally there is no air within the orbit. The most common source of air for it to enter the orbital cavity is through the surrounding sinuses. So it usually follows fractures. Okay, the other mechanisms that have been reported are infections because you may have some gas producing organisms, pulmonary barotrauma, injury from compressed air hoses, and complications during dental surgeries or dental procedures. So what happens if there is air within the orbit? So we all know that the orbit can have a closed compartment or a intraconal space. There is a lot of restriction. So what if the air gets trapped and it acts like a space occupying lesion there? So it can cause orbital compartment syndrome. So this can lead to proptosis, and if it is in very close proximity to the optic nerve, due to the increase in pressure, there can be damage to the optic nerve causing visual deterioration, and ophthalmic artery occlusion can also result. So the treatment depends on the magnitude, the ophthalmic features and the degree of proptosis. So if there is imminent danger to the optic nerve, the air has to be relieved and it's usually aspirated using a needle. Otherwise, we can wait and watch. So if it is the air is trapped under the eyelid as is shown in this case here, okay, you might find uh, subcutaneous crepitus. So crepitus indicates that there is air. Now let's move on to orbital hemorrhage. We can also call it as retrobulbar hemorrhage. Okay. So when we say retrobulbar hemorrhage, we are sticking to mostly the hemorrhage that is present within the intracorneal space. Okay. So if it is parabulbar, it is present in the parabulbar space. So parabulbar hemorrhage and retrobulbar hemorrhage together, we can group it under orbital hemorrhage. So usually there is a history of trauma and there might be orbital fractures. There may be accompanying emphysema. So again the signs and symptoms depend on how much bleed is present and where it is present. So in case if it is a intraconal space, then there is axial proptosis. If it is an extraconal or parabulbar space, you have the eccentric proptosis. So in case there is raised intraorbital pressure, there can be development of a compartment syndrome in which you have to do a lateral canthotomy and cantholysis to relieve the pressure on the optic nerve. If the pressure doesn't come down, then the orbital septum division can be performed through an incision to the skin. So what is orbital compartment syndrome? I have used this word at least 3 times now. So it is due to increase in the contents in the retrobulbar space. Okay. Since it's a small space, there is increase in pressure that becomes detrimental to the functioning of the optic nerve. So the perfusion is at stake and then the optic nerve function also goes down. So what are the symptoms? There is a lot of eye pain, visual deterioration. Then there might be RAPD field effects, raised intraocular pressure because the orbital pressure is transmitted to the eye and there is raised intraocular pressure. You might see pulsating retinal vessels and even retinal vein occlusion. So if this is not corrected in adequate time, the vision can be permanently lost due to vascular occlusions. Okay, coming to orbital foreign bodies, they are common in war injuries. So foreign bodies are usually gun pellets, fragments, and pencil, pen, wood, nail, anything. Okay, so the type of presentation depends on the type of foreign body. Some foreign bodies might stay inert and they may not present with lot of problems. Okay, some may present with a chronic discharging sinus and signs of orbital inflammation. So other symptoms are pain, impairment of vision, limitation of movement and proptosis. So if the orbital foreign body is present, in one particular quadrant, the eye movement will be restricted in that particular quadrant. So how do you detect them? You can detect them using various radiological methods, and these has to be the decision to select the type of radiological imaging depends on the history. If the history says there might be a wooden foreign body, there is no point doing the CTs. In such cases, X-ray and MRI will be helpful. Okay, if it is a metallic foreign body, you have to be ultra careful not to use MRI. You have to do a CT scan. So usually CT scan is the method of choice in most of the foreign bodies. So as such, orbital foreign bodies carry the risk of infection. Very rarely, there might be no infection. Okay, so you need to give them broad spectrum antibiotics and tetanus toxoid. So the treatment is removal of the foreign body, and it depends on the location and size. Let's take a question at this point. A 30-year-old truck driver was brought to the emergency with a history of road traffic accident, following which he has severe pain and redness in the right side of the head. Okay, so they have given that affected side is right. Okay, on examination there is lid edema and proptosis of the right eye. Proptosis and crepitus is felt along the superior orbital rim. So this is a very important feature here. The superior orbital rim, there is crepitus. So we are dealing with some fracture. So there might be fracture of the superior rim, and they're saying there is proptosis. So there might be also the roof that is involved. Okay. On inverting the lid, there is chemosis and diffuse conjunctival hemorrhage and restricted ocular motility. All the following clinical features point to an emergent management in this condition. So in this case, so this is orbital trauma. Okay. So because there is proptosis, there is a fracture, we are thinking probably there is some kind of orbital hemorrhage along with emphysema. Okay. So in such cases, what factors on examination would you pick to call it an emergency? Okay. So let's look at the options. Loss of corneal sensation. That's not important at all. RAPD, yes, because it is a function of the optic nerve function. Central retinal artery pulsation, yes, so it kind of reflects the amount of uh, or intraorbital pressure, decreased visual acuity, yes. So these are all these three are important factors when you are looking at an orbital trauma. So we are not really worried about corneal sensations in this case. Okay, so the right answer is A. Okay, let's move on to orbital fractures. So orbital fractures, it can involve the walls of the orbit or the rim of the orbit. Okay, or it can involve only the walls of the orbit without involving the rim. So let's look at each of them. Roof fracture, it's dangerous because there is the anterior cranial fossa above. Secondly, the optic nerve injury is very common because of the transmission forces. The vector forces travel along the roof into the optic canal, and optic nerve injuries are very common in roof fractures. Medial wall fractures, they usually involve the nasal, ethmoidal sinus and the medial wall of the orbit. And zygomatic fractures are also known as tripod fractures. So this is a favorite question for your examiners. Leaf foot fractures, actually dentists have to know more about this. However, let's learn about them in this chapter. So here the fracture is in the maxillary and the pterygoid bones. What is type 1? Type 1 is a low-lying fracture. It is a low transverse maxillary fracture. Can you see the fracture line here? Yeah. Involving the teeth and no orbital involvement. So you might get a question, which of these type of leaf foot fractures has an orbital involvement? The answer would be not type 1. So type 2, again let's see what type 2 is. Generally have a pyramidal configuration and involve the nasal, lacrimal and the maxillary bones as well as the medial orbital floors. So again there is orbital involvement here, correct? So it's involving the nasal and the medial bones of the orbit. Type 3 fractures is I used to call it as goggle fracture because the fracture line looks like the patient is wearing a goggle. So type 3 fractures cause craniofacial disjunction in which the entire facial skeleton is completely detached from the base of skull and suspended only by soft tissues. So when I was a postgraduate, I was unfortunate enough to see this fracture because it was so traumatizing to look at the lady who was attacked by her husband, and she had come to the casualty, and the whole of the you could feel the whole of the face move, independent of the rest of the skull. So, type 3 fractures, you can remember it as goggle fracture, and type 2 and type 3 are the ones which involve the orbit. Now, blowout fractures, when the orbital margins are intact but the walls are compromised. Okay, so the orbital, you won't see any fracture lines along the orbit, but you will see fracture in the walls. It usually results from blunt trauma with an object of size bigger than the base of the orbit. This history is very important. And usual history they give is that of a cricket ball. So the size of the object should be a little bigger than the base of the orbit. So the forces are transmitted into the contents of the orbit and which expand within the orbit, leading to backward displacement of the globe and fracture of the weakest point of the orbital wall. So that happens to be the medial wall. That's why most common site of blowout fracture is the medial wall, followed by the floor of the orbit. Okay, but floor of the orbit fracture is most favorite question for the examiners, and you might get an exam question in theory as well as your next. So we'll concentrate more on the blowout fracture that involves the floor of the orbit. So the contents, why is it called blowout? Because the contents are blown out of the orbit. So the contents may prolapse into the neighboring sinus and the muscle belly may be entrapped by a fractured bony segment. So what are the clinical features? You might see periorbital edema and ecchymosis, subcutaneous emphysema may be there. So what are the signs that are very specific to blowout fracture is? You might see restricted eye movement in the direction opposite to the gaze as the muscle. So if the belly is caught in the inferior floor, I mean the floor of the orbit, you may not be able to elevate the eye. If it is in the medial wall, the eye may not be able to abduct. So in ophthalmos, due to decrease in the orbital contents, and diplopia might be present in primary or secondary gaze. So paresthesia of the area supplied by the infraorbital nerve, that is on the cheek, that is seen in floor fractures. So what is force reduction test? In this, the eyeball is moved in the direction of restricted motility. Suppose the eyeball does not elevate because the inferior rectus is caught in the floor of the fracture of the floor of the orbit. So what we do is we use two forceps to hold the eyeball at the nasal and the temporal limbus, and under topical anesthesia we move the eye upwards. So if the eye freely moves up, that means the restriction is not due to, I mean the limitation of the movement is not due to restriction. Okay, so usually what happens in this is you'll not be able to move the muscle freely because it's caught in the fracture site. So how will you investigate? You can do an X-ray orbit. A water view is I would remember it as a person trying to drink water. So the patient's head is lifted up with the mouth open. Okay, so water view shows a teardrop sign due to the prolapse of the orbital contents into maxillary antrum. So nobody does X-ray now. We straight away go to the CT because now we can get a 3D construction. We can know the anterior-posterior extent of the orbital fracture, and if you want to plan the repair, it's easier with the CT scan. But because your examiners will still be fond of this water's view, they will ask this in the exam. So the picture I've shown here is of a CT scan coronal view that shows the fracture here and the prolapse of contents within the maxillary sinus. A 14-year-old boy presents with injury to his left eye with a cricket ball, following which he has severe pain and redness in the left eye. So when you see this cricket ball only, you should understand that probably we will go talking about the orbital blowout fracture. Okay. The boy has had 5 episodes of vomiting. He complains of diplopia. On examination, the rim is intact. However, the left globe has enophthalmos and restricted up gaze. So all these points here point towards the uh, floor of the orbit fracture, blowout fracture. Okay. So pick the false statement regarding this case. The probable site of fracture is the floor of the orbit. Correct. The repair of fracture can wait for 24 hours for the edema to resolve. No, the patient is very symptomatic here. He is having diplopia on primary case. So this is an emergent condition and the decision to operate should be taken fast. On X-ray, there is a teardrop sign expected. There is a loss of sensation over the ipsilateral maxillary area. Yes, this is due to the involvement of the infraorbital nerve that passes through the infraorbital canal, which is present along the floor of the orbit. So the answer here is B. So what are the indications for emergency repair of blowout fracture? Impinged muscle belly triggering oculocardiac reflex. If you go back to the question and remember, I said he has had 5 episodes of vomiting. So this is due to the oculocardiac reflex that is brought about by the triggering of the muscle. And then severe vertical diplopia in primary case. Okay. So these are the indications for emergency repair. So when do you say you can wait for some time? So you can wait for 5 to 10 days for the edema to reduce. You give steroids to decrease the inflammation and limit the fibrosis. So the conditions are if you are having diplopia within 30 degrees of primary case, there is significant in ophthalmos more than 2 mm, and the surgery involves how is the surgery performed? The surgery is with the use of allogenic or autogenous materials to repair the floor of the orbit after removing the contents of the orbit from the fracture site. So coming to orbital surgeries or orbitotomy. Orbitotomy literally means cutting a part of the orbit, but always it's not true. Okay, in orbitotomy you can also mean that you are entering the orbit. Okay, you don't have to remove a part of the bone or cut a part of the bone. You can enter the orbit through these incisions that I've shown here. So let's talk about lateral orbitotomy. Lateral orbitotomy is the most common approach of orbitotomy and indicated in most tumors like lacrimal tumors, dermoid, and retrobulbar masses. Now here you get lot of exposure. So stellar right incision A. This incision is of historic interest and it is the most common incision of orbitotomy. Okay, now we are more moving towards scarless surgery. So we want more cosmetic surgery. So a lid crease incision is the most common preferred incision these days. So B is the lid crease incision with lateral extension. Then modified Burki's lateral canthotomy incision is shown by C, and lateral canthotomy is a longer incision that is shown by I here. So coming to medial orbitotomy, we reserve it for lacrimal sac tumors and DCR. So that is done by a transcaruncular incision like this, or a Lynch incision, or a transconjunctival incision that is shown here, okay, along the limbus. Okay, anterior orbitotomy indicated for anterior orbital lesions that is shown by the superior transcutaneous or transconjunctival that is shown by F and J and K. So these are along the upper and the lower lids. Then superior orbitotomy is done for cranial fossa tumors that is through a transfrontal approach. The next orbital surgery we'll be dealing with is exentration. It is a destructive surgery. So three destructive surgeries in ophthalmology: evisceration, enucleation, and exentration. Evisceration is removal of the contents of the eyeball, leaving behind the sclera. Enucleation is removing the whole of the eyeball, leaving behind the extraocular muscles. Exentration is removing all the contents of the muscles, okay, along with the periosteum. So it is indicated in highly malignant tumors of the eye and the orbit, and a non-malignant condition such as mucormycosis is also treated by exentration. So we can perform exentration by two methods: lid sparing and lid sacrificing. In lid sparing methods, the incision is made along the lash line, just 4-5 mm behind the lash line. If this is the lashes here, upper lid and lower lid, the incision is made here, and this portion of the eyelid is removed along with the contents of the orbit. So much of the lid is left behind in the upper and the lower lid so that we can close the defect easily. In lid sacrificing exentration is usually reserved for conditions where you get lot of involvement of the lids by tumors. So in such cases, we allow the exposed part of the orbit to granulate, or we can use some graft. Which of the following structures is not removed in exentration? Extraocular muscles, conjunctiva, optic nerve, ethmoidal bone. So the right answer here is ethmoidal bone. The optic nerve is the last to be resected in exentration after we take out the whole of the eyeball. Which of this is not a malignant indication of exentration? Okay, so the right answer here is orbital mucormycosis. So why do we do exentration in orbital mucormycosis? Let's understand the pathophysiology. It is also known as ROCM or rhino-orbitocerebral mucormycosis. So it has a very high chance of entering the brain and causing mortality. So this is one condition in which you have to go for exentration even if the uh, eye has vision. Okay, when you have proven that there is mucormycosis, even in presence of vision, you have to go ahead with the exentration. So we have completed orbit chapter with these questions. Next, we will start with uvea. So happy learning to all of you.